Virginia in 2009 with a Bachelor's of Education in Speech Language Pathology and Audiology, and then from James Madison University in 2011 with her Master's of Science in Speech Language Pathology and Audiology. Lauren has worked for Valley Health as a speech language pathologist for 4 years, treating both adults and children in the areas of swallowing, articulation, language, cognition, and voice disorders. She has obtained a specialized certification for vital stem dysphagia therapy to further assist with the treatment of swallowing disorders. When we were having some swallowing difficulties with some of our participants at the center, we needed an in-service, and that's where I met Lauren, and she just did a fantastic job being able to help educate us how to better assist clients with swallowing difficulties. So I'm really happy she was able to be here today to share some insights with you as well.
Good morning. Can you all hear me? Thank you so much for having me here today. It's a pleasure to be here talking with you all about this very important topic of dysphagia, which is trouble swallowing. Sometimes you might hear it dysphagia, maybe you've never heard the term at all, but it is trouble swallowing. Some studies estimate that nearly 40% of individuals with dementia have dysphagia or will have it in their lifetime. So 40%, that's a huge number. So today I'd like to discuss some of the anatomy of the swallowing mechanism and familiarize you with the signs and symptoms of aspiration. Another term, aspiration, in case you've never heard of it, it's when things go down the wrong pipe. So whenever you're swallowing or you're drinking and you're coughing, that's aspiration. So just so we're on the same understanding there. All right. Here we go. So with that, I'd like to start by telling you what a speech-language pathologist or speech therapist really is. A lot of people are surprised that they're going to see a speech therapist. I don't have trouble saying my R sounds, is what a lot of people say. They think that we just work with children. However, we work with a lot of adults. We work in the hospital, we work in nursing homes. So I am fortunate that I get to work with people of all ages. I start in infancy all the way up until late adulthood. Broadly, we evaluate speech and language, cognitive and swallowing disorders in individuals from infancy through the geriatric population. Many patients with dementia, stroke, or Parkinson's disease begin to experience difficulties with their eating and swallowing. This could be a result of weakness of the muscles, incoordination, or a decline in cognitive status. An example of a decline in cognitive status would be if a person begins to have trouble with their attention. They are having a difficult time staying on track during mealtime. They might require an assistant or a caregiver to be there to prompt them, okay, you need to keep chewing, you need to swallow. Sometimes it's not that severe, but oftentimes the memory takes a toll on the swallowing as well. I thought I would also discuss how we evaluate the swallowing mechanism, because many people don't know what to expect when they come to see me. The first type of evaluation is called a bedside swallowing evaluation. It's an in-office assessment of swallowing abilities. The speech therapist gives the individual a variety of drink items, food items. We start with easier things like applesauce, kind of that puree consistency, and we move on to kind of a chop consistency. We give diced peaches. And then lastly, we give a cracker, kind of that dry consistency that requires a lot of chewing and a lot of effort. The goal of this study is to determine if they're swallowing safely. The second type of evaluation, it's a little bit more medical. It's called a cookie swallow study. The full name is called a modified barium swallow study. And what that is, it's very similar to the bedside. We give you food items and drink items, but this time we mix it with barium, and you do the study under x-ray at the hospital. So it's very similar, but a little bit more in depth, and we can actually see what's going on. Okay. Now, I'm hoping this works. I have some videos here that I'd like to show you. If it doesn't work, I'm very sorry, but I thought it would be a good,
Swallowing occurs in 2 stages, the oropharyngeal and esophageal stages. At the start of the swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis.
I'm going to pause it just for a second. So this is the esophagus here. That's the right way. We want the food to go down there, down to the stomach. This airway right here is the wrong pipe. So oftentimes individuals, when they swallow that food, instead of going down the esophagus, diverts and goes down the airway.
With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. The oropharyngeal stage is done and breathing resumes. During the esophageal stage, a primary wave of peristalsis initiated by the swallowing center pushes the bolus through the esophagus. As the bolus travels through the esophagus, the lower esophageal sphincter relaxes, allowing the food to enter the stomach. If the bolus is sticky and adheres to the esophagus, secondary peristaltic waves triggered by the intrinsic plexus at the point of distension completely clear the esophageal lumen to finish the swallow.
All right. So I thought that would be just an easier way to explain it. Sometimes just visualizing it for yourself is much better. Now, secondly, I'm going to show you a video of a cookie study. This is a normal study. So you can see the person, they're chewing, and all that black went down on the right side. That was a good study. That's what we want to see. Now, this study is an abnormal study. They are swallowing a thin liquid, something like a water, and you will see, it will be pretty obvious that they will have a pretty strong black line going down on the left side, and that is aspiration. Oh no. Okay, that's not good. And you can see they're not coughing. Okay? So, went down the wrong way, and if they would have coughed, you would have seen kind of them coughing, but they had really no idea that it went down the wrong way. Now that is called silent aspiration. Most of us would be overt aspirators. Whenever you cough, your body does things to make you try to expel what went down the wrong way. Obvious signs are coughing, choking, gagging, attempts to clear your throat. You kind of clear, try to get it out. Difficulty breathing, audible breathing, like it's really congested sounding or wheezing. Facial grimacing, a gurgly vocal quality. The individual says, I feel like there's something stuck there in my throat. Now, the individual that we just saw on the last study was a silent aspirator. So they might have more subtle signs, and those are signs that we are kind of trained, we've seen them time and time again. Their voice might be a little wet, or their eyes might kind of start to water, their face is red, their respiration kind of gets a little bit more labored, and they might be breathing a little more heavily. Over time, their lung sounds will change. All of that food and drink going down the wrong way, it goes to their lungs. They could end up with an aspiration pneumonia, so their lungs will sound congested. So those are all very important signs to watch for. Now, if you think that these are happening with your loved ones or the individuals that you're caring for, go talk with your doctor as soon as possible and get an evaluation done. It could either be at the hospital with the cookie study or an in-office assessment. But with dysphagia, it's very important to kind of get ahead of it. And again, like Dr. Fowler said, education is the best thing for treating. So the earlier, the better. Okay, so let's say during the cookie study or during the bedside swallowing evaluation, it was determined that they had trouble with some of the food items. Maybe not all the food items, but some of them. What we do is we try to modify the diet. So I'm going to talk about the national dysphagia diets. These are the solids. So the most, I would say, severe alteration in the food is what we call level 1 dysphagia pureed. And that is food items that are all the same. They're cohesive. There's very little chewing, if at all. It's foods like pudding or applesauce, mashed potatoes, things like that. I always tell my patients, try to eat foods that are naturally pureed. Because if not, you take a sandwich and you put it in a blender and you puree it, and no one would really want to eat that. So I always encourage everyone to really just stick with foods that are naturally in that state. The second level is called the dysphagia mechanical altered. And that is foods that require some chewing, but a lot of the work is already done. It's chopped up for you. So the green beans there, they're not whole green beans, but they're kind of already chopped. Or the peaches. This diet consistency isn't too bad. I don't think I'd have a difficult time with this. But it is certainly changed, especially meats. Oftentimes meats have to be kind of put in a chopper. Maybe they need some gravy to kind of help assist things go down. So it's certainly not the most appetizing. The next one is dysphagia advanced. It's mostly normal, more soft foods that require more chewing, but it avoids difficult food items like nuts or rice or popcorn, things that we might have trouble with occasionally. So an example of this consistency would be a sandwich. And then lastly, a regular diet. That's if they had no trouble at all with their solids, they could eat anything, all foods. All right, so next up are the liquids. How many of you all have heard of thickened liquids? Yes, okay. So I thought that I would demonstrate that for you today. So the drink that most of us would drink is thin liquids. Most drinks like water, iced tea, coffee, very thin. I brought some orange juice. Even orange juice is a little bit on the thicker side, but I would still consider it a thin liquid. Next up is a nectar thick liquid. And that's like Ensure or tomato juice. Kind of whenever you would pour it, it would kind of move a little bit slower. And then lastly is a honey thick liquid, like a milkshake. Again, these are all examples of drinks that are kind of naturally in that state. However, if you really want a water and you're on a recommendation of a honey thick liquid, then you're going to have to thicken it. So I brought some with me today. So this is just orange juice. And as I put there, some people use the Thicket, which is a powder thickener. However, here at the hospital a few years ago, we moved to Simply Thick. And the speech therapist at the hospital really pushed hard to get this thickener in the hospital because it's gel-based and it doesn't change consistency over time like the powder does. The powder, the longer it sits, the thicker it gets, and it gets fluffy and gloopy. So the gel is really good. I'm going to show you just how easy it is. And I've tasted it many times. I don't think the taste changes at all, but it certainly changes the consistency, which is unfortunately what we have to go for. So you just, for every 4 ounces of liquid, you put 1 packet, depending on the recommendation of the therapist. So this is a nectar thick, so it won't be too thick. And all you do is put it in the shaker and give it a shake for 10 seconds maybe. And it's done. And it will stay like that for days and days. People put it in the fridge. You can make a big jug of it, put it in the fridge, and it won't change over time. So we really like this thickener. Also, it's the Thicket oftentimes messes with the sugars. So if the patient is a diabetic as well, the thickener kind of adds sugar to that, whereas this does not. So we really like this thickener. All right. Now this next slide is a question I get a lot. Is it okay to sneak foods? Do I have to have all my foods pureed? So, this is one of those topics that it's tricky, it's hard, and for you as a loved one, I'm sure it's hard to, puree every food item or chop every food. So, there's a really tough balance between safety and quality of life. So many individuals sneak their favorite food, snacks, or beverages. It's important to work with your doctor and speech therapist to determine the safest way to maximize quality of life. An example would be to eat more difficult food items when the individual is most alert and adequately supervised. So, like I said before, the taste and the appeal of food obviously changes when it's chopped or pureed. Therefore, many individuals no longer take pleasure in eating. And as a result, it's often difficult to maintain adequate hydration and nutrition. So there really is a balance. Is it more important that they're not aspirating little bits of water, or is it more important that they're actually hydrated enough? So it's certainly, there is a tough balance there. Now, here are some of my tips for improving swallowing. Now, all of these suggestions are compensatory in nature, so they aren't going to improve the swallowing function. So let's talk about these first. So the first one is to decrease distraction. So limit the number of people at the table, turn off the TV, make things easier for them. Don't have a huge party, as they're eating lunch. Secondly, encourage the individual to not eat while talking. I often tell my patients, I will tell you to do anything your mama didn't tell you to do. Don't eat while your mouth is, don't talk while your mouth is full. Take smaller bites, smaller sips. Another good suggestion, if they're having trouble with the food kind of falling out the front, sometimes the sensation in their lips isn't quite as good, so they might have, the food kind of leak out the front. It's a good idea to put a mirror there at the table, and that way they can kind of watch themselves a little bit and kind of get that feedback. Oh, I need to wipe my mouth, or make my lips extra strong whenever I'm drinking from a straw, things like that. Select foods that are full of nutrients and calories. You want items that are the biggest bang for your buck. So again, if they're not eating 3 meals a day, when they are eating, give them things that are really nutrient packed. So Ensure, Boost, those will be your best friends as well. Encourage the individual to eat when he's most awake and alert. Promote independence with feeding if at all possible. There is a stage of the swallow. I didn't really talk about the stages of the swallow, but there is a stage, it's called the pre-oral phase. So it's actually, your brain is getting signals as your arm is taking that spoon and dipping it into the ice cream and bringing it towards your lips. It's kind of like anticipating, oh, I'm about to eat. So if you take away some of that and you're the one feeding them, then their brain isn't getting all of those signals until it's actually at their mouth. So if at all possible, or even if you have to use like a hand-over-hand motion, that would be better. Wear properly fitting dentures, and be aware of medication changes. Dr. Fowler talked about medication changes as well. So sometimes that can affect safety of the swallow and also just desire to eat. All right, so as I mentioned before, these are compensatory in nature. However, we do offer some treatment techniques that are rehabilitative in nature, so they actually will kind of strengthen those muscles again. So we offer exercises called oral motor exercises that aim to improve the strength and the coordination of the lips and the tongue, the face, and then these neck muscles. Additionally, we offer another tool. It's called Vital Stim, and most of our therapists over at the Rehab Center are certified. And I don't know if any of you have ever used a TENS unit. It's kind of similar, where we place electrodes on the neck, and you're actually in therapy and you're eating and you're swallowing with this machine turned on. I give the example, it's like you go to the gym, and if I go to the gym and I don't put any weights in my hands and I just do this 100 times, my muscles really aren't going to get stronger. But if I go and I put 20-pound weights in and do it, it's going to get stronger faster. So this machine, it's kind of like adding that extra weight. So you're swallowing, but there's resistance being added. So it does make it more difficult to swallow in the session, but hopefully over time, those muscles will strengthen. So that's just another option as well. Okay, next is the importance of oral care. So we did talk a little bit about aspiration, and if an individual is even aspirating their own saliva, if they're not brushing their teeth frequently enough or not seeking professional dental care enough, then that bacteria could be growing. And then as the bacteria is growing, it can be, if they're aspirating it, it's going down until into their lower respiratory tracts. So that could easily lead to pneumonia as well. So it's very, very important. The bacteria often grows more at a faster rate. Okay, so that kind of concludes my swallowing portion. I did want to touch a little bit on just some speech and language components and also memory as well. So oftentimes we use what we call AAC, augmentative and alternative communication. Many individuals with dementia or those with the history of a stroke or Parkinson's or TBI are unable to communicate effectively with their words. So as a result, we kind of need a workaround sometimes. They might need to use pictures or writing or gestures or letters to tell what they need or what they want. As I said, I'm not going to discuss a whole lot of this because every individual is so different. So if this is something that pertains to you or you'd like more information, I'd be happy to discuss it with you. But this is just one example of a communication board. And sometimes our individuals might not have the dexterity to point very carefully to these icons, so they can, of course, be changed. We could have some that just have 2 pictures on it, or just a yes or a no. There are also a lot of applications on iPads and tablets that it's kind of like a layering system. Like if you hit the hot drink button, it will change the screen to a list of choices. So there really are a lot of really neat tools out there. But this is just one example of an AAC, kind of like a low-tech device. All right. Now on to cognitive impairment. Speech therapists also evaluate and address cognitive areas such as attention, memory, planning, and problem solving. These individuals with dementia, the majority of the treatment focuses on compensatory strategies. As Dr. Fowler said earlier, unfortunately it's not going to get better, but we do everything that we can to kind of slow the process and to increase the quality of life. So we use journals and calendars to try to keep them as active and engaged as possible. And of course, family involvement is completely critical for treatment. So this is just the first page of my kind of large handout that I give people when they come for evaluation with me. It's just the first page of my memory cabinet, that way they don't have to open every cabinet. You can just read the labels. And then stay involved in household responsibilities. If they're having trouble with their finances, don't just take over the finances, but involve them in it as well. See if they can do one component, and then you can kind of do it alongside with them or check their work to make sure that it's accurate. All right, so that is all for today. My takeaway message is that it takes a team. You're not on your own, as the others have mentioned before me. We're all here for you. There's a team of dietitians, neurologists, doctors, neuropsychologists, therapists that are all here to optimize your success. So thank you so much.
Thank you, Lauren. I think what we're going to do now is take a few minutes to go in. We've got some more refreshments, and they are made available from Care Connections of